Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Thanks, Brian. So I actually think this was a relatively exciting update because there are lots of things to chew on and lots of surprises. And so I'm just going to run through what the guideline said, and we can talk at the end about whether or not this is going to impact people's practice. My disclosures, I don't know how long I have to keep saying this, but I attended a 2018 advisory meeting for Gilead, and then our typical that only FTC TDF and FTC TAF are approved by the U.S. Food and Drug Administration and only for use as daily PrEP in some but not all populations, and we will definitely be talking about other options and other medicines today. I just wanted to have this slide in here to, again, review what IAS-USA uses as their ratings. I believe there have been at least 2 other talks around these recommendations now, so I'm not going to go into these in depth, but you can go back and look at these strengths in terms of how you think about these recommendations. So the first thing I just want to say is who should be prescribed PrEP. There's nothing surprising on this slide. They said PrEP should be discussed with all sexually active adults and adolescents and individuals who inject drugs with a strong recommendation. They also say that FTC TDF is recommended for individuals who are pregnant or breastfeeding. Nothing controversial there. What to prescribe? This is sort of where the intrigue starts. So they come out and say that FTC TDF is the recommended oral PrEP regimen for all populations. Strongest recommendations based on randomized clinical trials. Daily FTC TAF, what we know as Descovy, is recommended for the subset of men who have sex with men with a estimated creatinine clearance between 30 and 60 who have a history of osteopenia or porosis and those at high risk for these. Note, there are a few typos in the guidelines that they are aware of. I went through and let them know all the typos. There is a missing comma in one of those places. So very clear, it's for folks who have the estimated creatinine clearance of 30 to 60 or who have a history of osteopenia or porosis. So as you read those, don't get confused that you need to have both. They say that either TDF tenofovir or TAF tenofovir alone are not recommended, either by the absence of evidence or the sort of relative weakness of these medicines alone. And then the surprise in here is that they recommended long-acting cabotegravir, pending FDA approval, of course, for cisgender men and transgender women, with, again, a slight discrepancy in the 2 places. In text and in table, there's some difference in their strength. A is just based on published manuscript. B is abstract, so eventually it will be an A. Currently it is a B. With, as Rafi discussed a few weeks ago when he talked about his study, that the oral lead-in period is optional. So something we can talk about, although not yet FDA approved. However, in the last week, as many of you probably know, these guidelines are already out of date, and something that we've been teasing Rafi about. But as you probably know, on Monday, there was a press release that said that HPTN 084, which is the sister study of HPTN 083, which looked at long-acting cabotegravir in cisgender women in Africa, that study was stopped early based on a planned DSMB interim review. So given that this study is not included in the guidelines, I just wanted to review it so you can see the strength of this evidence. And so 084 enrolled 3,200 cisgender women between the ages of 18 and 45 in 20 sites in different countries in sub-Saharan Africa, with a planned interim review last Thursday. And this is the data that they saw. In the CAB group, there were 4 infections for an incidence rate of 0.21%. In the FTC TDF oral arm, this was a placebo-controlled trial, if you remember from the description from HPTN 083. So people were on placebo, pill, placebo, CAB. I believe that's right. And there were 34 infections in the daily FTC TDF arm for an incidence rate of 1.79%. with a hazard ratio of just over 0.1%, indicating superiority of long-acting injectable CAB done every 2 months, every 8 weeks, compared to daily tenofovir. As is sort of not totally unexpected, in the subset of participants who had blood drawn, of 362 who were in the FTC-TDF oral PrEP arm, only 64% had any detectable level of tenofovir. So adherence, again, not perfect in this group, which is, again, one of the reasons why we think that long-acting cabotegravir may have benefit, because it doesn't require the same level of daily adherence. There were no safety concerns aside from pain and tenderness at injection sites. And as I mentioned earlier, this blinded phase has stopped, people going into open label. They can continue on oral PrEP if they would like. They can transition to long-acting CAB if and when it becomes available to them. There's probably some issues with manufacturer and them in the open label phase getting enough for all of the participants, but they will all have the option of being on whichever they prefer. So that's 084. Again, guidelines now out of date. Hopefully when the CDC guidelines come out, they will be up to date, including this information, but who knows? It's a very quickly moving field. Okay, back to guidelines. So how to prescribe PrEP. Here's another place where this guidelines actually says something different. For cisgender men who have sex with men, giving 2 pills of FTC-TDF on day 1 reduces time to maximal protection to 24 hours. And then in terms of how long to continue after exposures, they say for cisgender men who have sex with men, FTC-TDF should be continued for 2 days after the last at-risk exposure. Of course, these conclusions based on data from the EPRGA, from all of the 211, randomized and open label. But they are coming clearly on saying how long it takes to protection and moving very clearly away from the 28 days of post-exposure prophylaxis that I think is sort of what many of us would very conservatively recommend. For non-cisgender men who have sex with men, for everyone else, maximum protection is likely achieved in about 7 days after initiation of PrEP. And FTC-TDF should be continued. I seem to have missed that, and I'll have to look back. I don't know, Brian, if you can look while I'm talking about how many days after the last at-risk exposure that was. I don't remember whether it was 20. It stays at 28 days or not. We'll find that by the end of this talk and fill that in. 2-1-1 dosing recommended only for cisgender men who have sex with men. So I know there's been some discussion about whether 2-1-1 dosing would be appropriate for transgender folks. These guidelines are coming out as only for cisgender men who have sex with men. And as we know, no data is currently supporting 2-1-1 dosing for FTC-TAF. How to prescribe PrEP. PrEP should be started as soon as feasible. So they say if there's a negative HIV test, an antigen antibody test within 7 days, and no symptoms of acute HIV infection, fever, rash, sore throat, muscle aches, joint aches, anything at all, that they could initiate PrEP same day with a moderate recommendation. For oral PrEP, they're actually saying the initial prescription should be only 30 days and then 90 days thereafter, which is different, I think, than much of the practice of an initial prescription of 90 days. Baseline testing, there's nothing really surprising here. They continue to say that if you have point-of-care HIV testing, you can start PrEP, but a laboratory test should be sent. If there's clinical suspicion of acute HIV infection, then RNA testing should be sent and PrEP should not be started. However, if there's extremely high suspicion of acute HIV infection, that they recommend starting 3-drug therapy. I'm not going to read all of the recommendations for other baseline testing. These don't change at all. In terms of monitoring, they come out and say that HIV testing at 1 month is recommended and fairly strongly recommended based on expert opinion. Again, a slight discrepancy in what the strength of their recommendation was. And then quarterly testing. They recommend testing for kidney function for everyone at month 3 and then annually, to try and sort of back away. Kidney function doesn't change that all unless people are at risk, and they've actually outlined who those folks at risk are. They include people over 50 who had an estimated creatinine clearance of under 90 when they started, because those folks are more likely to drop under 60, and then anybody with comorbidities such as diabetes and hypertension. STD testing is now by them recommended quarterly. It's sort of not surprising. We've all basically been doing quarterly testing, but the guidelines hadn't said quarterly testing for all asymptomatic people. And of course, we're doing all sites pregnancy testing as needed. They make some comments about PrEP during COVID. And so, and telemedicine, which of course has expanded during COVID. And what they say is that patients who have stable visits with on-time refills can substitute telemedicine for in-person visits, assuming that you have laboratory testing results available for the visits. So for PrEP is fairly simple. Telemedicine can substitute for in-person. They go against what the CDC letter to providers said, and said that extending refills to 6 months is reasonable and should be individualized based on the same things we've talked about. So refill records, people's issues, need for more STD testing, things like that. So individualized, someone can extend from 3 to 6 months if for some reason they can't do in-person visits and you can't do laboratory assessments. They speak for the first time about persistence on PrEP and how do you retain people. And I thought this was an interesting section to read. So patients who discontinue PrEP because they no longer consider themselves at risk should have those assumptions reviewed and discussed. And the reason for that is, as you know, that many people discontinue PrEP or don't start PrEP because they believe themselves to be at low risk. And yet we know that many people continue to be at high risk after they discontinue PrEP. So addressing that concern, if you get someone back in the clinic after they've discontinued, is something that they feel is important. The obvious, if they discontinue due to economic or structural barriers, should have individualized assistance in getting them on insurance or other patient assistance programs. Again, as I said, this was because they have high rates of HIV acquisition following stop PrEP. And then the same recommendations that have been in previous guidelines in determining how long do you have to be off PrEP in order to have an HIV test before restarting. And they echo what past guidelines have said, that it is 7 days. If someone has been off PrEP for 7 days, whatever reason, they should have an HIV test prior to restarting. They touch on adherence. So the no-brainer of patients who have adherence challenge should be provided with individualized counseling. Those who are willing should be considered for alarms, pill boxes, electronic reminders, or text messaging services have been shown to improve adherence in subsets of populations. They speak to PEP and PrEP again, and so if a PEP candidate reports a high-risk condomless exposure in the last 72 hours, PEP should be done, as you would do, with 3 drugs, and then a seamless transition to PrEP. And then the question is always, does someone who is on PrEP need to have PEP in the setting of exposure? And as has been stated in the last CDC guidelines, in the setting of non-adherence, they recommend doing PEP for people on PrEP. And this set of guidelines actually specifies what they believe to be non-adherence. So if you have a patient on PrEP and they are a cisgender man or a transgender woman, and they have been taking less than 4 doses per week per average they don't give a time frame. So let's say, last few weeks, less than 4 doses on average, they should be started on PEP. Anyone who's maintained more than 4 doses on average does not need PEP, but should continue PrEP with obviously some conversation about supporting their adherence. This is different than cisgender women, people who inject drugs, and heterosexual men, in which non-adherence is defined as under 6 doses in the last week. But go out to help put an objective measurement onto what is non-adherence and how do we decide when to give someone PEP when they have been, in quotes, on PrEP. They make a comment about transgender women and supporting maximal adherence. I assume these guidelines didn't incorporate any of the iBreathe data that we reviewed a few weeks ago. I still, in my practice, am really trying to emphasize adherence for everyone except for cisgender men who have a little bit more flexibility and missing occasional doses, but they call out transgender women in particular as being populations that need to have adherence supported, and they cite the data that suggested that hormones might reduce levels of PrEP. They also provide more specificity about PrEP failures. Most PrEP failure due to poor medication adherence. We know this, and therefore most infections are going to be with wild-type HIV. But they come out to say that even if someone has had PrEP failure and has acquired or been transmitted a M184V or K65R mutation, that our traditional medication regimens that include TDF, TAF, plus FTC 3-TC should still be expected to achieve high rates of viral suppression. And then in someone who has acquired HIV while on PrEP, we should obviously be sending those genotypes and tailoring regimens based on that. But the recommendation of sort of what typically to start is unchanged in someone who is quote unquote PrEP failure, because again, most PrEP failures are due to non-adherence and therefore will be wild type. I'm going to stop sharing so I can look at I just saw all those pop-ups for all the chats. I'm hoping one of those is how long? 7 days after the last risk.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.